Well, first of all, I would like to thank you for the invitation. It's a pleasure to be here. But I will start. I apologize because I'm not able to speak in your own language. I hope in the near future I am able to speak at least the Portuñol, and then you can understand better. Well, today I will try to bring some scientific evidence for the clinical practice in progesterone in preterm birth. So, I would like to deliver this presentation just in two topics. The first topic is, why should I have take progesterone? And the second topic is, when should I have take progesterone? And in order to answer the second question, I would like to present scientific evidence and finalize, demonstrate the right patient to take progesterone and the wrong patient to take progesterone. I will start by one mean. Progesterone is a medicine. And as a medicine, when I give progesterone, I try to find pharmacological properties for indication of progesterone. I'm not going to give progesterone because there is some withdrawal of progesterone. I will give progesterone because progesterone is a medicine, and as a medicine, there is pharmacological properties. So, I give progesterone first because progesterone decreases the estrogen receptors, and we learn today that estrogen is important for contraction. If I stop estrogen receptor, I'm not going to have contraction, and the muscle, the uterine muscle, is still relaxed. Progesterone inhibits the synthesis of oxytocin receptors, and if there is no oxytocin, there is no contractions. Once I want contraction, in induction of labor, I give oxytocin. I give progesterone because progesterone increases synthesis of beta-adrenergic receptors. And beta-adrenergic receptor is important for relax myometrium muscle. When I give ritodrine, when I give terbutaline, I'm able to stop contraction. I give progesterone as well because progesterone decreases free calcium into the cytoplasma and increase calcium in the sarcoplasmatic reticulum. And without calcium, there is no contraction. So, the first reason why I give progesterone is because progesterone is against contraction. And the second reason why I give progesterone is because progesterone is a medicine and has a structure similar of steroids. Therefore, progesterone has anti-inflammatory properties. And we know that labor is inflammation. I don't know if infection leading inflammation, but I know that is inflammation. Doesn't matter is premature, doesn't matter if a term labor is inflammation. So this is the reason why I give progesterone. Second question, when should I give progesterone? When should I take the decision for progesterone? In order to answer this question, I need to understand the strategy for prevention of preterm birth. And nowadays, the strategy is identification of risk. And there are just three important risks that means that, that there are just three risks that need to be asked for the patient. The first risk factor is previous history of preterm birth. The second risk factor is twin pregnancy. And the third risk factor is short cervical length at mid gestation scan. And now, it's not Eduardo from Brazil, the silly boy. Now is Roberto Romero, and Roberto Romero said, cervical length is not a screen test for spontaneous preterm delivery. Cervical length should be for determination, cervical length is not a screening test for spontaneous preterm delivery. However, determination of cervical length is a powerful method for risk assessment, and this method should be asked for care, prenatal care. So, in the way that I ask for the patient, how was your previous pregnancy? How many babies you have in your womb? I should ask her, how are your cervix? And now, you learn how you can ask this. Just ask for vaginal scan. Now goes to progesterone. The history of progesterone goes back to 1970. Actually, it's not new. Progesterone, I think, is older than me. It started with Emily Papernik, and he was the first one to demonstrate that progesterone works for patients with previous history of preterm birth. In 1970, he demonstrated that just by taking progesterone, there is reduction in the rate of preterm birth. Following his first paper, came several papers from Europe, from US, and in 1990, Michael Kurz, the father of the meta-analysis, has demonstrated in the British Journal Obstetrics and Gynecology that just by taking progesterone, we will reduce the rate of preterm delivery, we will reduce the preterm labor, and we will reduce the low birth weight by roughly 50%. So, I'm going to bring now not new things. I'm going to bring now old things in a new version. So, in 2003, we brought this paper who reborn the interest of progesterone. In this study, we took 152 single pregnant women at risk for preterm delivery due to one of the following risk factors. One previous history of preterm birth, incompetent cervix, and uterine malformation. These patients were randomized either to take micronized progesterone, 100 milligrams from 28 to 34 weeks, or placebo. And in this study, we found a reduction of 50% for birth less than 37 weeks, and a reduction of 85% for birth less than 34 weeks. From this picture, we learn that the higher the risk for preterm birth, the better the effect of progesterone. In this study, we conclude first that progesterone halves the incidence of preterm delivery, 50% less. Second thing, by taking progesterone, there is a reduction in the frequency of contraction. As you can see in this picture, we check the uterine contraction by cardiotocography, by CTG, from 28 to 34 weeks, and the progesterone group has much less contraction when compared to the placebo group. And the third important thing that we find, and is on the bottom line, is that progesterone improves the beta-adrenergic tocolytic response. In this study, the rate of preterm birth was about 20% in the progesterone group, and it was about 30% in the placebo group. It's quite similar. There was no difference, probably because the power calculation was done for preterm delivery less than 37 weeks. It doesn't matter, because when I have a patient in labor, what the first thing that I should do? I should stop contraction in order to give steroids, beta, metazona, 12 milligrams today, 12 milligrams tomorrow, and wait 24 hours after. This is the reason for tocolysis. So I need delayed delivery in order to give steroids. So on the bottom line, progesterone group, the delay over 72 hours was 85% rather than 36% in the placebo group, which means that if I'm not able to avoid preterm delivery, I can at least delay in order to give steroids for this patient. Well, just one paper? No, we need to find other paper. So in this paper, Settingos in 2011 evaluate 150 pregnant women at high risk of preterm birth. And this risk was due to previous preterm birth, twin pregnancies, or uterine malformations. And the question at that time was, progesterone is going to work in patients with previous history of preterm birth just by itself, or progesterone plays in patient with previous history of preterm birth because they had shorter cervical length. And then Settingos has checked the cervical length before randomization, and there was no difference in the cervical length in the placebo group compared to the progesterone group. Same cervix, only historical risk factor. And the results was that one. Prophylactic vaginal micronized progesterone reduced the rate of preterm birth from 45 to 25%, reduced the rate of preterm delivery in a high-risk pregnancies in singleton from 28 to 8.8%, and it was significant, but there was a reduction in twins, but this reduction was not significant. What was not new for us. Progesterone reduced the birth result in neonate intensive care unit admission from 37 to 16%. So, following these papers, ECOG gave us their recommendation. So in 2003, ECOG said, despite apparent evidence suggesting efficacy of progesterone in the prevention of preterm birth, the ideal progesterone formulations is a no. I don't know what is the best one in 2003. However, progesterone should be restricted to women with documented history of spontaneous preterm birth until the optimal formulation and long-term safety are assessed. In a very polite way, they finish like that. Further studies are needed to evaluate the use of progesterone in patients with other risk factors, such as twins, short cervix, and positive fibronectin. Well, first question. Previous preterm birth, progesterone works. Let's go for the second question. Short cervix, progesterone works or not? Well, before to go for the second question, we need to understand few things in order to give the best dose of progesterone. In this very good study, wonderful number, 600, O'Brien randomized patient with previous history of preterm birth to receive either 19 milligrams of progesterone or placebo. In this study, he couldn't find any difference between placebo and progesterone for deliveries less than 37, less than 35, and less than 32 weeks. So now we have a problem. We have studies that demonstrate that progesterone works in patients with previous history. And now we have a big study with 611 patients that demonstrate that progesterone does not work. Well, let's change now the ACOG recommendation and stop to give progesterone for patients with previous history, or let's go and try to understand better this very good study and understand what is behind the line. The time and the formulation of progesterone used was vaginal suppository of 100 milligrams at night in the previous studies. And O'Brien took 90 milligrams a day of bioadhesive in the morning. Let me ask something for the audience. I believe that most of you here, when have a patient with some discharge, give her some cream, some vaginal cream. And with time, the day, we'll give this cream. In the morning, when the patient is very happy because she's going to her job, or you are going to give her this cream at night when the patient is going to the bed. What's the best time to give something by vaginal route? Help me. Night. So what happened? Give in the morning, probably progesterone goes out. So the lower dose given in the morning could be associated with missed active drug during the day. Therefore, it might have a lower concentration in the myometrium, and its benefit could be concentrated only in the cervix by its anti-inflammatory properties. But the anti-contraction action was not played in this scenario. So let's go further. And then O'Brien asked for DiFranco, get his numbers and reanalyze them. So he took from the big study with 611 patients, he took 46 patients that had a short cervical length. And 19 was in the progesterone group and 27 was in the placebo group. What he found? He found that progesterone works in short cervix. So birth less than 32 weeks was 0% in the progesterone group and was 30% in the placebo group, which means less dose in the morning, lose some effect, but when the cervix was short, the anti-inflammatory properties work and there was no delivery. There were few admissions in the neonatal intensive care unit in the progesterone group, short neonatal intensive care unit stay, and there was a trend toward the decreased neonatal RDS from 29% to 5%, which means that vaginal progesterone, even in the morning, is going to work in patients with short cervix. But they were not happy. Come on, it's not good, and then it's good. So, therefore, he took 547 patients in this big study, and they checked the cervical length at 18-23 weeks, and then check again at 28 weeks. Progesterone and placebo. Conclusion, progesterone enhance the preservation of cervical length in women with a prior history of preterm birth. So, this study found any benefit of vaginal progesterone even in the wrong time, in the morning. Well, let's move for short cervix. So, in this study, we evaluate the micronized progesterone, 200 milligrams at night, at 24 to 34 weeks. In order to answer this, we took 30,000 patients. We asked her to have a cervical assessment at the mid-trimester scan, we found 400 patients with short cervix less than 15 millimeters and 250 patients accept to be randomized for vaginal progesterone or placebo. Two questions. First, question one, why now 200 milligrams? On the beginning was 100 milligrams, and then we moved for 200 milligrams. What's the reason for 200 milligrams? Do you have an idea? We are talking about cervical length of 15 millimeters. I know you all has eyes in the finger, isn't it? Do you have eyes in the finger? Cervical examination. So my finger has 1.5 centimeters, 15 millimeters, which means that here was the baby's head, and here was the vagina, and there was just one finger between baby's head and the vagina. So this patient is a very, very high risk. According to Roberto Romero, this short cervix, it's not screening, it's risk assessment once cervical length is more powerful than history, previous history. So because this we select 200 milligrams. And secondly, we took 15 millimeters of length because we select the group with a very high risk group. Actually, the risk of preterm birth is start increasing from less than 25 millimeters, goes a bit up, less than 20 millimeters, and there is a exponential increase when it's less than 15 millimeters. So we took 15 just because we would like to have the higher risk in order to understand if progesterone would work or not. So in this study, we found that delivery before 34 weeks was about 34% in the placebo and was 19% in the progesterone group, which means a reduction of 44%. 50% for previous history. 44% make things easier. 50% at previous history, and 45% for short cervical length. 50, 45. But again, ECOG needs to give us advice. ECOG 2008. Let's change now. Progesterone in the prevention of recurrent preterm birth should be offered. It's not more should be restricted. It should be offered to women at symptom pregnancy and prior spontaneous preterm birth due to spontaneous preterm labor or premature rupture of membrane. First advice remains, progesterone works in previous history of preterm birth. Second advice, current evidence does not support the routine use of progesterone in women with twins pregnancies. Third advice, progesterone for asymptomatic women with incidentally identify very short cervical length, less than 15 millimeters, may be considered. However, routine cervical length screen, it's not recommended so far. The ECOG and the Society of Maternal-Fetal Medicine believe that further studies are needed to determine if there are any other indication for progesterone therapy for the prevention of preterm birth. In the beginning was progesterone supplementation, but now is therapy. We went from vitamin and now we have antibiotics. Vitamin supplementation. Maybe you need, maybe you don't need. Now, antibiotics is therapy. You need. So now we need further studies for progesterone therapy. Okay? And just a couple of weeks ago, the Roberto Romero group brought this very nice paper, quite similar to the previous one in the New England Journal. He took 32,000 women he found about 700 short cervical length, between 10 and 20 millimeters, and the reason to move from 15 to 20 was like that. I know that progesterone works less than 15 millimeters. Now I need to understand if progesterone is going to work between 15 and 20 millimeters in order to have scientific evidence to give progesterone for patient less than 20 millimeters. Then he randomized 458 patients to take vaginal progesterone or placebo. And what he found? First, reduction in the rate of preterm birth from 16 to 8.9% in the progesterone arm. He found a reduction on the respiratory distress syndrome from 7 to 3.6%, and a reduction of any morbidity or mortality from 13.5% to 7.7%. And their conclusion was reduction of 45% and progesterone improves neonatal outcome. Third question, twins, work or not? I told you that I'm not going to bring new things, just old things. So far, everything is old, apart from the cervical length. Old scientific evidence, 1908, 143 patients, twins, there was no difference regarding gestational age of delivery, birth weight, or neonatal outcome. Give progesterone, give water, give potatoes, give Big Mac, give Coca, give whatever you want. There is no difference. Progesterone does not work for twins. But we need to do something new. So let's do. 661 patients. Rules, New England, 2007. Randomized for 17p progesterone and placebo. No difference for the liver less than 35, less than 32, less than 28 weeks. And the conclusion was the same that was given by Hartington, in 1908. 17p failed to lower the rate of preterm birth and improve neonatal outcome. But we need more to prove that does not work, because twins is a main problem nowadays. Norma took 500 patients, randomized for vaginal progesterone, primary outcome, delivery or induction of labor less than 34 weeks, analysis by intentional to treat, and there was no difference. Progesterone group, 24% rate of preterm birth. Placebo, 20%. No difference in progesterone in placebo group. So progesterone does not work for twins. Here we are. Progesterone for preventing preterm birth. What should I do? First, find the right patient. And in order to find the right patient, we need to understand the strategy for prevention of preterm birth. And first step is identification of risk. Please help me. What are the risks? Cervical length, previous preterm, and twins. Excellent. Work here, progesterone, yes or no? Work here, yes or no? And here? Excellent. Score 10 for every single one in the audience. So select the right patient and give micronized progesterone vaginally from 100 to 300 once or twice a day from 16-20 to 34-36 weeks. This is the main things that I would like to show today. But let me bring something else and then we finish this issue. Obstetrical good practice. Where are we? When we talk about obstetrician, we talk about magnesium sulfate for eclampsia, isn't it? We have to use. We talk now about magnesium sulfate sulfate for cerebral palsy, less than 32 weeks. Should we use? They told us yes. We talk about steroids. According to J. Irons, the most important thing in the last 13 years old for lung maturation. Look there. Eclampsia sulfate magnase. Magnase sulfate. I will have a reduction of 60% of eclampsia. There will be no difference in the maternal mortality, and I need to treat 100 patients in order to prevent one eclampsia. This is not me, Cochrane database. Cerebral palsy. In order to have a reduction of 32%, I have to treat 63 patients to prevent one cerebral palsy. And steroids for lung maturation, in order to have a reduction of 47%, isn't it 47? 50, 45. Here is 47. I need to treat 9 patients from 5 to 37. Here we are. Let's see progesterone. Progesterone, where are you? Previous preterm birth and short cervix. There are the only evidence so far. In order to prevent preterm birth, 20% of reduction, I need to treat only 7 patients from range from 4 to 17. Is progesterone safe? Short cervical length. In order to reduce preterm birth, I will have a reduction of 32%, and I need to treat 14 patients from 8 to 8.7. And in order to have improvement in the neonatal outcome, lung RDS, 61% of reduction, neonatal sepsis, about 72% of reduction, any morbidity, any mortality, 43% of reduction. I need to treat 22 patients from 12 to 186. So the answer is with you. What shall we do? Well, I will take the comments of J. Irons in 2003. Although it's not yet time to treat 2003 all women at risk for preterm birth with supplemental progesterone, 2003, it's not too soon to hope that this early report will be followed by large series showing not only a decline in the preterm birth, but a reduction in perinatal morbidity and mortality as well. And now, in front of me is Barack Obama, and he says, yes, we can. Reduction of perinatal morbidity and mortality. Thank you very much.